Spinal cord injuries. Overview, Anatomy of the spinal cord case presentation. Spinal cord injuries. Classification. Complete and incomplete syndromes. Respiratory complications of spinal cord injuries. ICU management of spinal cord injuries. Pharmacological management. Gross anatomy. Begins at the foramen magnum of the skull, where it is continuous with the medulla oblongata. Cervical enlargement gives rise to the brachial plexus. Lumbar enlargement gives rise to the lumbosacral plexus. Tapers inferiorly to the conus medullaris, from here the filum terminale attaches to the coccyx. Lower end of the spinal cord lies at the lower border of L1. Vertebral column is much longer than the spinal column, so the cord segments do not correspond numerically to the vertebral bodies. Columns of the spinal cord. Spinal column stabilized by three major ligaments. Anterior longitudinal ligament. Posterior longitudinal ligament. Ligamentum flavum. Anterior column, anterior 2/3 vertebral bodies and the anterior ligament. Middle column, posterior 1/3 vertebral bodies and the posterior ligament. Posterior column, ligamentum flavum and everything else. Injury involving greater than one column is considered unstable. Spinal cord structure. Inner core of gray matter, surrounded by an outer covering of white matter. Gray matter is arranged in an H shape, with anterior and posterior horns, joined by a thin gray commissure which contains the central canal. The T1-L3 segments also contain a lateral gray horn. Gray matter of the spinal cord. The anterior horn is divided into medial, central and lateral columns. Medial group is present in most segments innervating the skeletal muscles of the neck and trunk. Central group is the smallest and is present in some cervical and lumbosacral segments. Lateral group is present in the cervical and lumbosacral segments, innervates the skeletal muscles of the limbs. Posterior horn has 4 different groups of nerve cells. Substantia gelatinosa group. Nucleus proprius. Nucleus dorsalis. Visceral afferent nucleus. Lateral gray horns contain preganglionic sympathetic fibers. Tracts of the spinal cord. Ascending, sensory. Dorsal, posterior, columns, deep touch, proprioception, vibration. Lateral spinothalamic, pain and temperature. Anterior spinothalamic, light touch. Descending, motor. Lateral corticospinal, voluntary motor. Anterior corticospinal, voluntary skilled motor. Rubrospinal, control of movement. Vestibulospinal, posture and balance. Tectospinal, reflex postural movements in response to visual stimuli. Spinal cord injuries causes. Majority caused by MVAS, falls, iatrogenic. Mostly young males, but the other demographic includes older people with concurrent degenerative spinal canal narrowing. Frequently associated with other conditions. Shock syndromes. Other injuries. A likely story. Say hello to Jim. 85-year-old male who slipped backwards and hit head-on tow bar behind car. Presented to Tenterfield Hospital, then TF to Armidale, where CT showed unstable C4/5 #. Transferred to JHH for NSXRV. Conscious and spontaneously breathing. Hard collar in situ, but poorly fitting. GIS 13, E3V4M6, Pearl. BG, metastatic prostate CA, HTN, T2DM. Jim's imaging. Unstable C4/5 fracture. Further examination. Normal cranial nerve examination. Decreased strength, 2/5, and absent reflexes bilaterally in upper limbs. Decreased pain and temperature sensation bilateral hands. Normal strength, 5/5, reflexes and sensation in bilateral lower limbs. Developed urinary retention. American Spinal Injury Association Neurological Impairment Scale. Classifications: quadriplegia, paraplegia, complete, incomplete. Injury to the cervical spine, leading to impairment in the arms, trunk, pelvis and legs. Paraplegia. Injury to the thoracic, lumbar or sacral segments, leading to impairment in the trunk, legs and pelvic organs. Complete. No motor or sensory function below the affect level. Incomplete. Some preserved motor or sensory function below the affected level. Complete injury: no voluntary anal contraction. 0.5 distal motor score. 0.2 sensory score. Bulbar cavernous reflex present. Incomplete spinal cord injuries. Anterior cord syndrome. Central cord syndrome. Brown-Sequard syndrome. Posterior cord syndrome. Anterior spinal cord syndrome. Injury to the anterior spinal cord caused by either direct compression of the spinal cord, or damage to the anterior spinal artery. Usually from a flexion/compression injury. Bilateral loss of pain, temperature and light touch below the lesion due to disruption of the anterior and lateral spinothalamic tracts. Motor dysfunction due to the disruption of the anterior corticospinal tracts, and damage to the anterior gray horn neurons. Worst prognosis of incomplete SCI. 10 to 20% chance motor recovery. Anterior, central spinal cord syndrome. Most common incomplete spinal cord injury. Often in the elderly with extension injury mechanisms, due to anterior osteophytes and posterior enfolded ligaments. Motor dysfunction due to disruption of the lateral corticospinal tracts and damage to the anterior gray horn neurons. Bladder and bowel involvement. Bilateral loss of pain, temperature and light touch due to disruption of the spinothalamic tracts. Sacral sparing. Good prognosis, but unlikely to regain full function. Anterior. Brown-Sequard syndrome. Caused by complete cord hemitransection. Ipsilateral motor dysfunction, with LMN weakness at the level of the injury, and UMN signs below the injury. Ipsilateral proprioception and vibration loss due to posterior column damage. Contralateral pain and temperature loss 2 to 3 segments below the lesion due to disruption of the spinothalamic tracts. Good prognosis. Posterior cord syndrome. Rare syndrome. Most commonly caused by vascular compromise, with occlusion to the posterior spinal artery. Sensory dysfunction with ipsilateral loss of proprioception and vibration, and preservation of pain and temperature. Anterior. Cauda-equina syndrome. Caused by damage to the cauda equina, a collection of S1L5 nerves. Technically a peripheral nerve lesion, so will cause lower motor neuron signs. Presentation. Saddle anesthesia, bilateral lower limb sensory motor loss and pain, bowel and bladder symptoms, especially urinary retention. Absent or reduced lower limb reflexes, decreased rectal tone. MRI best to evaluate nerve compression. Needs urgent surgical decompression within 48 hours. Jim's progress notes. Admitted under NSX. few episodes of vomiting on ward, during which he likely aspirated. RT on ward for respiratory arrest, intubated and TF to ICU. Some more stuff happened. Improved and ready to trial extubation. Unfortunately, he failed extubation due to hypoxia. Why? Respiratory complications with SCI. Spinal cord level. Muscle involvement. Effect on respiration. Clinical consequence. C13. Complete paralysis of all respiratory muscles. Vital capacity only 5 to 10% of normal, absent cough. Apnea and immediate death. C36. Varied impairment of diaphragmatic contraction. Vital capacity 20% of normal, weak and ineffective cough. Ventilation necessary in acute stages, majority will be weaned from mechanical ventilation. C68. Diaphragm and accessory cervical inspiratory muscles intact. Intercostals and abdominal muscles intact. Expiration entirely passive. Secretion retention. No respiratory failure unless coexisting lung/chest injury/illness. T24. Vital capacity 30 to 50% normal, and weak cough. SCI effects on breathing. Loss of intercostal function. Failure of AP expansion of the rib cage. Chest wall sucked in during diaphragmatic contraction. Loss of lower thoracic segment innervation. Diaphragm starts in a flatter position, which decreases contraction pressure. Loss of abdominal muscle tone. As the diaphragm flattens, abdominal contents are pushed outwards and the lower rib cage is pulled inwards, causing paradoxical seesaw breathing. Diaphragm is pulled down by the weight of the abdomen. Inefficient, rapid, shallow breathing results, with more dead space ventilation. Abdominal muscle weakness results in decreased ability to cough and clear secretions. ICU management of SCI patients. Respiratory management. Airway management. Physiotherapy. Posture. Mucolytics. Abdominal binding. Monitor for infection. Bronchoscopy. Longer-term respiratory care. Tracheostomy. More comfortable, minimized laryngeal damage, less dead space compared to ETT, associated with fewer respiratory infections. Weaning from ventilation. Portex sprints are as effective or better than PS weaning, with both superior to SIMF weaning. Cardiovascular complications after SCI. Neurogenic shock. Occurs with lesions above T6 due to loss of sympathetic tone and unopposed parasympathetic tone. Vasodilation and hypotension, bradycardia. Thromboembolism. Due to immobility and venous stasis. Sympathetic hyperreflexia. Unopposed sympathetic tone below the level of injury, triggered by sensory stimuli. Gastrointestinal complications after SCI. Delayed gastric emptying and ileus. Common and may last 2 to 3 weeks. Aperients, early feeding, NGT, prokinetic agents. Gastric stress ulceration. PPI prophylaxis. Constipation, metabolic system considerations. Temperature regulation. Hypothermic due to vasodilation. Hypothermic due to inability to sweat below level of injury. Hyperglycemia. Common due to stress response. Worsens ischemic neurological injury. Pharmacological treatment of SCI. Steroids. Previously, high-dose methylprednisone was standard of care for SCI. Since shown to significantly increase mortality in patients, compared to placebo. No-go antibody. No-Go-A is an inhibitory molecule that prevents neuronal plasticity and axonal regeneration. Current clinical trial to determine effects of an intrathecal infusion of No-Go-A antibody.